So sepsis. Sepsis basically starts with a local infection that enters the blood, and that infection leads to the systemic inflammatory response syndrome, and that's basically what sepsis is. Organisms that normally cause sepsis can be gram-negative organisms such as Klebsiella, E. coli, or Pseudomonas, or even gram-positive organisms such as staph or strep. And in patients who are immunocompromised, like your patients who have cancer or HIV, even fungal infections can lead to sepsis. In order to diagnose sepsis, the patient has to have an infection, and two of these manifestations of systemic inflammatory response syndrome, and then one of these clinical manifestations. So the criteria for systemic inflammatory response syndrome is an increase in temp of 104 or a decrease in temp of 96.8, an increase in heart rate above 90, and an increase in respiratory rate above 20. The CO2 below 32, so they're going to be acidotic, a WBC above 12,000 or below 4,000, and that increase in the immature bands. Okay, so remember, the criteria to diagnose sepsis is to have an infection, to have two of these items here under the systemic inflammatory response syndrome, and then at least one of these clinical manifestations. So under the clinical manifestations, they'll have a decreased urine output, decreased blood pressure, decrease in cap refill, that increase in blood sugar, even though they don't have diabetes, the changes in LOC, and that elevation in creatinine. And so we know that they have a decrease in urine output, right, because of the decreased perfusion. And decrease in urine output is going to cause this creatinine and to go up relatively. And 2 in men, 1.4 in women, because men generally creatinine runs a little higher than women. This decrease in blood pressure and decrease in cap refill, same thing, it's due to decreased perfusion. And the blood sugar will become elevated due to that stress response. The liver will increase the glucose release, and that's why you see this increase in blood sugar even though the patient does not have diabetes. And this change in LOC is due to that decreased perfusion. And so remember, in sepsis, there are a lot of fluid shifts due to that huge inflammatory response. And the fluid shifts are caused by this vasodilation and these leaky vessels leading to blood pooling. What happens as well is the WBCs will produce these pro-inflammatory cytokines, and which further increase that inflammatory response. And the endotoxins released by the bacteria cause changes in our endothelial cells, causing these tiny little clots all over the body, and that the patient will feel pain, and they'll feel this they'll feel pain due to the ischemia. And the skin may be pale, maybe it's already like slightly cyanotic, maybe a little bit clammy. You'll see this increase in procalcitonin. Procalcitonin is a good way to measure effectiveness of therapy as well, because as the bacterial level in your blood goes up, the procalcitonin levels go up. So as bacterial levels goes down due to antibiotic therapy, or the patient's body's fighting off the infection, you'll see this procalcitonin level decrease. You see this decrease in activated protein C. Activated protein C in the body basically prevents inappropriate clots, and this decrease in activated protein C is another reason why you see these little clots all over the body as well. And as we spoke about earlier, this increase in blood sugar due to the liver just releasing more sugar due to the stress response. And the WBCs, they're in the early sepsis, they'll be slightly elevated. So I just put normal here, 5,000 to 10,000. So So you'll see this slight elevation or an elevation in early sepsis. And then the creatinine, normal creatinine is 0.5 to 1.2, and you'll see an elevation in creatinine too due to that decrease in urine output. The serum lactate level will go up, and you know that's due to anaerobic metabolism. So there's hypoxia all over the body, and anaerobic metabolism is basically metabolism without oxygen. So that's why you see this increase in lactic acid. And it's very important to remember this because the levels change as the sepsis gets worse. And in the early stages, you'll have decreased perfusion due to this huge vasodilation, so there's less blood in the vascular space, right? So you have a decreased cardiac output, decreased stroke volume, an increase in heart rate because you know that as blood pressure goes down, the heart rate's going to go up. And then decreased perfusion to the kidneys, and the kidneys are trying to hold on to the fluid that you have in your body, so you have a decrease in your output. And we already talked about this cool and pale skin due to decreased perfusion, and then also this ischemia going on with these little clots. And then due to decreased perfusion to the brain, the patient might be restless, and there'll be change in LOC. The patient might just say something like, I feel like something's really wrong, but I really don't know what. So changes in just their behavior from the norm. Okay, so this is severe sepsis. Severe sepsis is, the criteria for severe sepsis is all the things we said earlier, sepsis plus some sort of organ dysfunction, pretty severe, or hypotension. So if she wrote a question, it might be like, you know, all the symptoms of sepsis, and also a blood pressure like below 90, a systolic below 90. And so you know that the patient's getting worse, and they might be, they might have severe sepsis now. And or hypoperfusion. Hypoperfusion is basically decreased perfusion to the body, and you'll see that cyanosis, or increase in heart rate, decrease in urine output, changes in LOC. Those are all indications of hypoperfusion. Okay, so they don't always have to go together. Hypotension and hypoperfusion don't always have to go together. And now they have the widespread DIC. So before, when they have those little, just the microthrombi all over the body causing pain and ischemia, now not only is there clots, but there's also bleeding because all those clotting factors are being used up, right? So you'll see that significant decrease, the significant increase in the D-dimer. And the D-dimer is basically a protein that will increase in the body due to the fibrinogen being broken down. So increase in D-dimer, and then the decrease in protein C, and you'll just continue to see this decrease in protein C. And that's important because one of the interventions is to actually give them some synthetic protein C. And as a reminder, protein C is something in the body that prevents this inappropriate clotting, okay? So you'll see a decrease in that. Blood sugars 120 to 150. So before it could have just been maybe like 110 to 120 in the early stages. Now we're seeing blood sugars up to 120 to 150. And now the WBCs are actually decreasing because the bone marrow is not able to keep up with the need because of this huge infection. So now WBCs might actually be normal or actually go down. And you'll see that increase in the immature neutrophils and continued decrease in urine output. Before, the lactic acid might have been just a little bit above 1 in the early stages, but now we're talking about 2 to 4. And these are pretty high numbers. And as a reminder, it's due to anaerobic metabolism in the body. And you'll see that this causes or leads to metabolic acidosis as well. And you know, as perfusion goes down, you'll see this decreased saturation, and it might be even below 85%. And then you'll see creatinine levels rise above 2 in men and above 1.4 in women. As before, it might have just been up to this point, but now we're talking about numbers much higher than normal values, which are, you know, regular normal creatinine levels are 0.5 to 1.2. And this is very important to understand. At this stage, the heart is going to compensate and actually work a little bit overtime. And so in severe sepsis, the patient might look better, but they're really not better. And there's this when you reach severe sepsis, the decline into septic shock is actually pretty rapid, but it's hard to catch because the symptoms are really not that profound, and during severe sepsis the patient actually doesn't look that bad because the heart compensates and the cardiac output goes up, the stroke volume goes up, the heart rate goes up, the blood pressure goes up, and their extremities in the early stages they were cool and clammy, but in the severe septic stage they're actually warm. And this is due to the inability for the body to shunt blood into the vital organs anymore. That protective mechanism has been lost, and now there's just massive vasodilation, and that's why you see warm extremities. And then, last but not least, septic shock. So, and septic shock is defined by hypotension despite fluid resuscitation. So if you see anything about, blood pressure being really low, and even though we're giving them all these IV fluids, the blood pressure continues to be low. And at this point, there's uncontrolled bleeding all over the body, and there's more multi-organ failure and hypoperfusion. So the death rate now for patients in septic shock are very, very high, and they have a high risk for ARDS as well, due to all this that's going on, the toxic metabolites and the hypoperfusion, the hypoxia, basically causes damage to the lungs, and patients that have this respiratory distress syndrome have a really, really high chance of dying. So this is something that we look for and treat immediately. Okay, and then now the lactate levels during septic shock are above 4. So before, during severe sepsis, when it was 2 to 4, now it's above 4. The blood sugar before would have been like 120 to 150 in severe sepsis. In septic shock, it's well above 150. The saturation has go down below 80%. We know we're in a lot of trouble. The respiratory rate is going to go up to try to compensate for that. But due to the metabolic acidosis that's going on, you're going to have that deeper breathing, trying to blow off some of that CO2. And then a huge left shift with an increase in immature neutrophils by maybe even 10%. And then, of course, a decrease in the mature neutrophils. And the skin will be pale because even during the severe sepsis, when the cardiac output went up to compensate, no, it's no longer doing that. The heart's ischemic, there's multi-organ failure, and now the skin will be very pale and cool. And you'll continue to see that activated protein C, right? Because you have uncontrolled bleeding, so you see a decrease in that. And then in the very, very late stages, when there's tons of bleeding, when there's increased bleeding, you'll see this decrease in hemoglobin, hematocrit, platelets, and fibrin. So all those numbers are going to go down, and as we said before, cardiac output and stroke volume go down during septic shock. Okay, I hope that helped. Next video, we'll go over interventions.